Bismillahirrahmanirrahim. I am Professor Dr. Zwan Zafar Ahmed. I am Professor of Medicine. And today we are going to talk about a very important topic that is limbs for life. I am thankful to Firoz Sons for arranging this educational activity and it would lead to prevention of so many feet from damages and rehabilitation back to normal life. We are going to talk about diabetic offloading devices and they are used to treat or prevent foot ulcers. As we know, the diabetes is on rise and there is global impact. Pakistan is third in world ranking in diabetes and similarly the risk of complication including diabetic neuropathy with outcome of diabetic ulcers is very common and a lot of masses still are unaware. The objective of this talk is to try to prevent such foot-related anatomical and morphological complications. So the purpose of offloading devices is to redistribute pressure on plantar surfaces, thereby reducing the risk of foot ulcers and infection. This is the ultimate objective. Common offloading modalities include removable cast walkers and total contact casting. For example, total contact casting uses fiberglass or plasters to support lower legs by redistributing pressure from the ulcers to the entire foot. Redistributing pressure helps to manage swelling and reduces the risk of foot infections. Total contact casting and removable cast walkers appears to be clinically effective. One systemic review of randomized controlled trials found that healing rates for patients who were treated by total contact casting was between 74% and 95%, and for removable cast walker was 52 and 85%. One systemic review found that non-removable offloading devices such as total contact casting confers better outcome for diabetic foot ulcers. Treatment than removable devices by limiting patient's ability to remove the device, thereby increase adherence. Forefoot, this presents the generalized swelling of the forefoot and osteonecrosis of the metatarsal heads. It is rare for a significant structural deformity to develop in forefoot. Young type 1 diabetic women are known to have osteopenia and are susceptible to fractures, including foot fractures. Midfoot, this is the commonest site of presentation of Charcot's osteoarthropathy and it is recognized clinically by the rocker bottom deformity and medial convexity. The rocker bottom deformity develops when there is disintegration and displacement of the cuneiform or the proximal tarsal bones, resulting in collapse of the midfoot. Rocker bottom deformity is frequently associated with plantar ulceration. As shown in the picture, the hindfoot, the early presentation is of swollen ankle. Later, there is severe structural deformity and instability of the ankle joints. This can lead to flail ankle on which it is impossible to walk. Forefoot, this as shown again in the picture, this usually stabilizes without bony deformity, but patients may need molded insoles in Bespoke shoes. Midfoot, when the midfoot has stabilized, the patient can now progress from a total cast, contact cast to a bivalve cast or air cast, fitted with a cradled molded insole. When the patient comes out of the cast, there will be wasting of the calf muscle and joint stiffness. They may be there. The crow. The crow basically means Charcot restraint orthotic walker. It's form of walker. And the Bespoke bivalve total contact device which externally fixates the ankle. Extra internal paddling has been added to cushion the vulnerable medial malleolar area. The yellow contiguous contains ethyl vinyl acetate, that is EVA, to strengthen the device without increasing the bulk All internal metal rivets have extra padding. The rigid, durable outer shell is constructed out of propyl, propylene and is linked with EVA. There is a bespoke molded insole to accommodate any existing deformity and to redistribute plantar pressures. AFO, this is ankle foot orthosis. It's a device as shown in the picture and used to stabilize the foot and ankle. There are two main forms of AFO, the traditional conventional metal and the leather caliper, and the newer thermoplastic types which are more cosmetic. Now we'll just have a case study, that is constructive management of Charcot's osteoarthropathy of the hind foot. A 46 years old male with type 1 diabetes of 40 years duration presented with bilateral Charcot's osteoarthropathy. He was referred from a clinic 80 miles away and had been advised to have a right below knee amputation. The left foot had stable midfoot Charcot's osteoarthropathy with rocker bottom deformity. The right foot was hot with unstable hindfoot Charcot's osteoarthropathy with lateral talotibiofibular displacement. The Charcot's arthropathy was diagnosed 3 years previously following a first ray amputation. As an alternative, the treatment plan was to try to achieve stability by providing a Crowe's form of boot. After 5 weeks in the crow, swelling had improved and the skin temperature differences between the 2 feet was less than 2 degrees centigrade. The patient was advised to take 5 to 10 steps daily for the first week and then at each week to double the step taken. At 10 months, he was taking up to 50 steps daily and the temperature difference was still less than 2 degrees centigrade. At this stage, there was clinical and radiological evidence that the hindfoot had stabilized. He remained in AFO for his long-term orthotic prescription. The majority of deformities in stage 2 can be accommodated in special footwear. Callus is an important precursor of ulceration and should be treated aggressively, especially in the neuropathic foot. The cold, pink, painful foot is an indication of severe ischemia and requires urgent vascular intervention. Patient must understand the implication of lack of protective pain sensation. Education in trauma prevention is important. Patients with painful neuropathy will need therapy of various modalities which should be delivered in a sportive environment. Early diagnosis, immediate cast immobilization, and careful rehabilitation are important for successful management of Charcot's osteoarthropathy. Various casts are available and their use is governed by local experience and expertise. Techniques include total contact cast, Scott cast boot, air cast, that is walking brace. So this is the Scott cast boot and this in between in the middle is the ortho wedge shoe to offload the forefoot and the last is air cast. A 40 years old male with type 1 diabetes and 30 years duration, proliferative retinopathy treated with laser photocoagulation, sensory neuropathy and autonomic neuropathy including postural hypotension developed an acute right midfoot Charcot's osteoarthropathy. Because of a previous episode of severe sepsis, he was reluctant to wear a total contact cast. He suffered a fall in his home where the kitchen floor was covered with the shiny linoleum and X-ray revealed a fracture of the tibial plateau, which progressed to a Charcot's osteoarthropathy of the knee. A plaster of Paris cylinder was applied for 6 months, followed by a knee brace. Felt paddling. Felt paddling may be used to divert pressure as shown in this picture from ulcers but can prevent complications from being detected if the paddling covers a large area. Felt paddling should be lifted regularly and should not be used as a substitute for good footwear and insoles. The felt use is made of sheep's wool with a hypoallergenic adhesive backing and is similar to the felt used within total contact cast and scout cast boots. Crutches. Young and active patients with neuropathic ulcers may do well with crutches as an adjunct to other pressure alleviating techniques. However, patients with impaired joint position, sense, or postural hypertension may be unsteady on crutches. Many patients with diabetes of long duration, especially the elderly, do very poorly with crutches and are prone to falls. It is important to check for Romberg sign before dispensing crutches. Walking sticks, these must be correct length and should have a non-slip cover on the end. Wheelchairs, a wheelchair which is used constantly is the best offloading device of all. Self-device models are better than chairs which can only be pushed. An extending platform can be tagged to elevate the foot. Zimmer frame. These are exceedingly useful stability and offloading aids. Unfortunately, they are associated with elderly and frail patients, and some young patients will not use them. However, many patients who cannot cope with the crutches find that a Zimmer frame is more helpful, being lightweight and providing more stability. So, offloading devices reducing plantar stress when worn, they lead to less stress on ulcer pec steps. It further leads to less stress on ulcer per day with positive effects, that is ulcer healing. Similarly, offloading device reducing plantar stress when worn leads to gait and balance difficulties, lower gait velocity, which you know may lead to less stress on the ulcer steps, then gait and balance difficulties, then less daily weight bearing activity and negative effects, that is daily activities, falls, health, etc. So diabetic patient journey basically includes diabetes mellitus, it with sensory neuropathies, then decreased pain, temperature and proprioception, motor neuropathies, autonomic neuropathies, and ultimately foot deformities, callus formation, and neuropathic foot and plantar ulcers and all that. So this is the form of a shoes showing high, uh, ankle high, low. The tongue and the laces or the cloyer should be adequate. There must be some space between the uppers and the forefoot, and similarly, it should be well balanced and healed, and it all must be uniform. So question 1. The presentation with generalized swelling of the forefoot and osteonecrosis of the metatarsal heads. Answer: the forefoot. Question 2. Healing rashes for patients who were treated by total contact casting was. The correct answer is 74 to 95%. Question 3. The Bespoke bivalve total contact device which externally fixates the ankle known as. The correct answer is the crow. With this, I thank you very much for patient listening. I complete my presentation. Thank you very much.